Welcome back to The Explainer. Today, we're jumping right into some seriously intense, high-stakes scenarios. Postoperative airway and venous emergencies. In the post-op ward, things can go from totally stable to absolutely life-threatening in literally seconds. So this explainer is essentially a clinical vignette masterclass. We're going to sharpen those diagnostic reflexes and transform these high-pressure scenarios into clear, life-saving actions using hard, evidence-based data. Let's get into it.
Okay, let's dive into this. Here's our clinical roadmap for today. 1. Airway emergencies. 2. DVT risks and diagnosis. 3. Anticoagulation and IVC filters. 4. Acute pulmonary embolism management. And 5. Critical perioperative thresholds.
Starting right off with Section 1, Airway Emergencies. Recognizing and managing tension hematomas.
All right, picture this. You're on the floor, and you get paged to this exact scenario. A 40-year-old female, just a few hours post-thyroidectomy, suddenly develops progressive neck swelling and stridor. You act fast, and boom, immediate intubation is successful. But what is your absolute most appropriate next step? Is it A, laryngoscopy, B, active observation, C, antibiotics and debridement, D, wound exploration, or E, antihistamines and steroids? Take a second and lock in your answer. All right, so the correct intervention is D, urgent wound exploration. Why? Well, this is the classic textbook presentation of a tension hematoma. You've already secured the airway, which is always priority number 1. But you can't just stop there. The definitive next step is taking this patient urgently back to the OR to surgically explore the wound, drain that expanding blood clot, and ligate the bleeding vessels. Now, what if you couldn't get the tube in? This right here is your bedside emergency protocol. Don't wait for a difficult airway cart or waste precious time drawing up steroids. You do this. 1. Pull the skin staples immediately. 2. Open those deep fascial layers right there at the bedside. And 3. Decompress the trachea. Releasing that hydrostatic tension restores airway patency before you even attempt a rescue airway. It is literally a lifesaver.
Section 2. DVT risks and diagnosis. Identifying thromboembolic threats.
Moving to the lower extremities, here's our next clinical vignette. We've got a 35-year-old female who has been bedridden for 7 days because of a femur fracture. She's also taking oral contraceptives. Today, she's complaining of severe left calf pain. So, what's the probable diagnosis here? Is it A, deep venous thrombosis, B, a drug reaction, C, arterial thrombosis, D, cellulitis, or E, lymphangitis? The diagnosis is absolutely A, deep venous thrombosis. Now, what's really interesting here is how perfectly her history aligns with Virchow's triad. Just look at this framework. We've got stasis because she's been bedridden for 7 days. We have endothelial injury from the trauma of the femur fracture, and hypercoagulability. That's being driven by the exogenous estrogen in her OCPs. Literally all 3 boxes are checked.
To really grasp DVT risk, we have to compare what promotes venous stasis versus what prevents it. Things like congestive heart failure, obesity, malignancy, and varicose veins, they all promote stasis by either slowing down circulation or causing physical compression. Contrast that with an ambulatory patient. When you're just walking around normally, your calf muscle pump is mechanically active. That constant venous return actually prevents stasis, making simple ambulation a massively protective factor.
So, here's a huge exam pearl for you. The non-invasive diagnostic standard for a suspected DVT is compression duplex ultrasonography. It's fast, inexpensive, and done right at the bedside. The key finding you're looking for? A complete lack of venous compressibility. Basically, if the vein doesn't compress under the ultrasound probe, a clot is blocking it. And this carries a roughly 95% accuracy for infrainguinal clots. Pretty incredible, right? Okay, Section 3. Anticoagulation and IVC filters. Halting the bleed and stopping the clot.
I really want to anchor your memory on this specific number, 5,000. When you're treating a DVT, 5,000 units is the standard therapeutic starting dose for an unfractionated heparin infusion.
But here's the catch. Anticoagulation carries immense risk. Think about this vignette. A young patient on a heparin infusion for a DVT suddenly develops bloody vomiting, hematemesis. What is your immediate next step? You're caught in this crazy clinical paradox, right? They absolutely need anticoagulation for the clot, but they are actively bleeding out. Do you A, observe the dose? B, stop heparin, give protamine, place an IVC filter? C, lower the heparin dose?
D. Stop heparin, start endoscopic sclerotherapy. Or E. Stop heparin, give FFP and warfarin.
The correct answer is B. You have to jump on this exact heparin reversal sequence immediately. First, cease the heparin infusion. Second, administer the antidote protamine sulfate. But remember, they still have an active DVT that could break off. Since anticoagulation is now off the table, step 3 is placing an inferior vena cava, or IVC filter, to mechanically catch any migrating clots.
And that brings us to the absolute indications for placing those IVC filters. You don't just put them in everyone. The evidence strictly mandates them for a proven acute VTE with active internal hemorrhage, a proven acute VTE with a major complication from anticoagulation, or recurrent VTEs or PEs despite therapeutic anticoagulation.
Section 4. Acute pulmonary embolism management. Immediate systemic interventions.
Now, if a DVT goes untreated, we hit the most dangerous complication. Here's the scenario. A hemodynamically stable female post-pelvic surgery has a confirmed acute right pulmonary embolus with a low oxygen saturation of 81%. What's the very first step? A. Heparin infusion. B. Oral warfarin therapy. C. Place IVC filter. D. Thrombolytic therapy with streptokinase. Or E. Surgical embolectomy.
So the crucial point is right here. The correct answer is A. Start a heparin infusion immediately. Why? It's the warfarin initiation rule. Heparin acts instantly to prevent clot propagation. Warfarin, on the other hand, takes days to act and initially creates a transient procoagulant state, which is the absolute last thing you want right now. And those thrombolytics or surgery, those are strictly reserved for massive PEs with shock and hemodynamic instability.
All right, let's wrap up with Section 5, critical perioperative thresholds, hard data for resuscitation.
I want you to remember this hard number, less than 6. In modern perioperative care, we use restrictive transfusion strategies, but if a patient's hemoglobin drops below 6 grams per deciliter, you've crossed a definitive red line. That is the threshold where a red blood cell transfusion is strongly indicated to save systemic oxygen delivery.
And what about neurological thresholds? An altered level of consciousness is defined here as a Glasgow Coma Scale, or GCS, score of 8 or less. Why does this matter so much? Because at a GCS of 8, the patient actually loses their protective airway reflexes, like coughing and gagging. This creates an unacceptably high risk for silent gastric aspiration.
Which brings us to one of the most famous clinical rules of thumb in medicine. GCS of 8, intubate. That altered level of consciousness is the single most common indication for endotracheal intubation. If they can't protect their airway, we have to step in and protect it for them. So we've covered a ton of critical ground today, from popping staples on a tension hematoma to reversing heparin during a massive bleed. My final question for you is, when seconds count in the postoperative ward, will you be ready to transform clinical observation into life-saving action? Keep these structured rules and thresholds in your back pocket, and you absolutely will be. Thanks for tuning in to The Explainer and for learning with us today.